Okay, good morning, everybody. We're going to get started here right now. I'd like to welcome everyone to the AUR Radiology Research Alliance Task Force presentations. The RRA task forces are focused on discussing how new changes in technology affect the way we practice radiology and medicine as a whole. And so we'll start with our task force presentations right now. The first task force to present will be Big Data in Radiology with Drs. Consagra, and please forgive if I mispronounced it, and Ali.
Thank you very much. So welcome everybody, good morning. I'm Akash Consagra, and today I'll be telling you about what we've been talking about in the Big Data and Radiology Task Force. So first, a little bit of background. So in terms of data in medicine, historically we've generated data in medicine through controlled experiments, whether that's laboratory work or clinical trials. But if you think about it, the vast majority of the data we collect is actually outside of these controlled settings, just in the course of normal clinical operations. Every time we run a lab test, every time a nurse takes vital signs, each of these is a critical piece of information that, by and large, we have thus far largely avoided, or ignored, rather. However, with increasing adoption of electronic medical records, this huge volume of data is now being stored in a format that's accessible and analyzable. So now, what is big data? So big data is a set of methodologies for analyzing huge, rapidly growing data sets that are pulled from a variety of sources. And traditionally, these are the exact sorts of data sets that have proved problematic for conventional analytic methods. So big data is a set of methodologies that are specifically designed for these data sets and can perform real-time analytics in these data. These methodologies have been used to great effect by retail and technology sectors. So every time you go to Amazon and it makes a recommendation, that's based on big data methods on the back end. But medicine is just starting to catch on to the promise and potential of these techniques. Now, what does this mean for radiology? So radiology is positioned to be our front runner in big data clinical informatics. And the reason for that is twofold. So one, we went all digital many years ago. So we have about a decade or a decade and a half of a head start on every other specialty in this area. In addition, we have for the most part, a robust IT infrastructure. This is one of the core ingredients of a big data informatics program, and we already have it. So with that in mind, big data is going to be a big part of the future of radiology and medicine in general. Now, big data is a big topic. So our task force has started the work of planning for the future using a two-pronged approach. One, we're going to lay out a vision of the future, and the way we're going to do that is we'll be talking about 4 big questions that come up in modern radiology practice and describe how big data can help to finally answer or address some of these questions. 2, we'll chart a path forward. So we'll talk about the big data adoption cycle and what that adoption cycle means for academic departments and how academic departments can promote big data development within their departments. So with that in mind, I'll turn the floor over to Dr. Ali.
So how can image interpretation be personalized for individual patients? So when you're reporting an imaging finding on a patient, generally what we tend to do is we tend to lump these findings into category A, category B, just very big groups of findings. And when you're attempting to personalize the findings now, you have to take several things into consideration. The patient factors and the population variables. Patient factors are the clinical history, the family history, the physical examination, lab values, and if available, the gene mutation status. The population variables would include things like disease prevalence, age, gender, and race. So that's kind of the standard things that we look out for when we're looking at an obvious finding on a study. But the importance of big data, not just the obvious pathology, but also for looking at the incidental findings. A lot of times we overutilize imaging. You read a belly CT, you see something in the bone, you end up doing a bone scan, an MRI, and it's really not indicated. So if you have this really large database of findings on a large number of patients, as well as data from clinical trials, then you can take that, integrate it, in sort of a real-time fashion, determine whether that patient needs to be followed up or not. So the existing management algorithms generally uses lesion size, patient age, and that sort of standard things to look at a finding. But the goal ultimately would be to be in front of your PACS workstation, looking at a study, have your PACS EHR integration, where you can basically pull up or integrate the patient's clinical findings with what you're seeing on the imaging study and compare that to a very large database of patients with similar comparable findings. And also, from these large clinical screening trials, you can take the data from that as well as the patient-specific population data and come up with a real-time diagnosis and personalize your imaging finding for that particular patient and make a personalized recommendation as well on that particular individual, rather than kind of painting a brush on the patient and saying, well, this is a one-size-fits-all kind of diagnosis. An example would be the National Lung Cancer Screening Trial. That's reduced mortality in high-risk patients by about 20%. But you have to remember the high-risk population doesn't represent all patients. So again, if you have all that info in front of you, you can make more educated and more reasonable recommendations for that particular individual. I think the next speaker.
So our little group looked to see if we can identify new information in existing imaging data. So the idea is that each exam contains a lot of data, and radiologists are basically data processors. So we take this huge chunk of data and we have a small report that supposedly summarizes everything. But in reality, we're not perfect. So if you can somehow apply big data analytics and look at voxel by voxel, there may be imaging phenotypes that we're not capturing, and these imaging phenotypes potentially can improve the care for various diseases. So big data analytics can potentially help with that. It's a hard to read slide, but the other advantage of big data is you can combine these imaging phenotypes with clinical phenotypes and figure out how to combine them in ways that are clinically useful that can help manage disease. And one example that we give in the paper, and here is that of Alzheimer's and the precursor of mild cognitive impairment. So ideally, if you can take patients with mild cognitive impairment and figure out which patients progress to Alzheimer's, that can really improve patient care. And there's one initiative that's doing exactly that. So the Alzheimer's disease neuroimaging initiative basically takes a big data approach, combines data from multiple centers, and combines radiology imaging data with clinical data, and they can stratify risk of people developing Alzheimer's disease in the future, stratifying it in this particular example from 3% to 69%, depending whether you do one MRI or multiple MRI. So the approach is not new. It's been used in other fields. For example, in the osteoporosis field, the FRAX initiatives takes the bone density data and clinical risk factors and combines it to do prognosis and determine who to treat. But the advantage of big data analytics is that it can take really huge amount of imaging phenotypes that we may not be using yet and use it to help guide care. So that's my spiel.
So to continue with the next handoff, so the next big question in radiology is, what is the value of any given imaging study? Now value, which is roughly defined as the outcome benefit relative to the cost penalty of any intervention, whether it's imaging or otherwise, is a key feature of new reimbursement models such as the ACO model of care. Now, that's conceptually very easy to understand, but it turns out it's quite difficult to quantify. And the reason is that imaging doesn't occur in isolation, but it triggers a very complex sequence of downstream events. And each link in that chain contributes or detracts from overall value to the patient. And in addition, value depends on the value of resulting treatment. So a perfect test that's very cheap that can recognize a diagnosis for which there's no good treatment may not have great value in the grand scheme of things. And to give an example, just consider this diagram. So if you have an imaging test, it can lead you down any one of 3 pathways. You can confirm a suspected diagnosis. It could tell the clinician there's an alternate diagnosis they should be entertaining, or it could raise incidental diagnoses. Each of these pathways has their own separate value associated with it. And the net value of the imaging test is a weighted sum of all of these different possibilities. So where does big data fit into this? Well, it turns out that because there's so many chains, or so many links in that chain of care, it's difficult to assign a specific value to each one unless you have very large data sets that can look at and exploit variations in practice patterns over hundreds and thousands, tens of thousands of practitioners, many institutions, to figure out, each individual step, and capturing that huge amount of data sets or data from multiple sources requires this big data methods. So I'll just give one specific example. So say you're working in the emergency, or working in an emergency radiology department, and you have a 30-year-old patient, a female patient with shortness of breath and who's on oral contraceptives. So we're trained to think, automatically, possibly PE, right? But that specific patient has a specific pretest probability of having a PE that's different than a 90-year-old cancer patient who's not on oral contraceptives. So already there's some data that goes into determining the pretest probability, as Dr. Ali talked about. Now, where does imaging fit into this? So you have 2 options once presented with that patient. You can either pursue a PE protocol CT, in which case you can then implement imaging-based treatment or non-treatment of that patient. The value of that option is the presumed positive value that it provides for patients who do have a PE, the positive or negative value for patients with an alternative diagnosis. So if they have a lung cancer, then early detection may have a positive value in that patient. But if they have a lung nodule that will ultimately prove to be benign, you can imagine that detecting that nodule in the grand scheme of things didn't actually help the patient. And then finally, the negative intrinsic value of the test, just the cost of performing the test, the risks of the contrast bolus, the radiation associated with it. So all those things go into the overall value of that PE study. Now you can compare that with empiric treatment or non-treatment of possible PE. That comes with the presumed positive value for patients who do have PE, as well as presumably a significant negative value for patients who are mistreated.
Our group was tasked on how we can assess and optimize radiology workflow. And as we know, the traditional contained workflow was a paper-generated request for an order and then spewed out a paper-generated report. However, we know since the advent of PACS in '82 that our radiology's workflow has become extremely complex and has been fundamentally altered. We now have the electronic order coming through our EMR, facilitated with decision support. It goes through scheduling in our RIS system and then undergoes image acquisition and image interpretation through the PACS. Then we have a generated electronic report through voice recognition system. We utilize critical results notification, and the electronic report then goes out to our clinician who reviews that report. The cycle is completed by having a peer review system, which allows us to evaluate and optimize many of these systems along the way, most importantly, the image interpretation. As we know, though, with this large amount of data, for those who are doing the research, it's very difficult to understand each of these fragmented segments. So what the business world or business intelligence tools have provided for us is a nice way to organize this data. And utilizing this data then now has allowed us to be able to glean specifics of this information in order to better provide quality improvement, optimize our workforce, and have greater efficiency. So why big data? Well, it's important for not only our institutions, but across healthcare systems and with the national system itself. So within our own system, these complex databases can then give us information to identify, for example, an institutional bottleneck for which we can provide a solution for improving staffing efficiency and for other quality improvement measures. And then across healthcare systems can provide solutions to provide improved diagnostic algorithms and decision support tools. Now, the ACR provided the National Radiology Data Registry, which provides dosage information on CTs, mammography results, and patient turnaround times. And by utilizing these large data sets and algorithms, we can then provide better imaging utilization as well as provide national benchmarks for quality that all institutions and individuals can utilize. What it also provides us is information gleaned from a large diagnostic algorithm that can be utilized by radiologists, technologists, and administrators in order to better provide greater quality care, quality workforce improvement, and efficiency that have great effect in these areas: resource utilization, diagnostic algorithms, and peer review. So with regard to resource utilization, we gave an example about how using this data you can predict when volumes increase and decrease over time. Therefore, you can staff an individual institution according to those specific metrics. For diagnostic algorithms, we looked at the child who comes into the children's hospital with right lower quadrant pain, and typically an ultrasound is performed. And in that specific setting, there's great sensitivity and specificity. However, by looking at some of the data, perhaps if that sonographer is not pediatric trained or someone is not as comfortable, is that as specific and sensitive? So utilizing the data for children seen in non-pediatric centers or those who had a CT after ultrasound or CT before ultrasound, another diagnostic algorithm could be utilized with great data backing. And finally, the national peer review, there is the RAD peer that the ACR has provided, and it also gives us an example of something that we can have that's very robust and can enable us to provide greater national benchmark databases. So with that, I will then go on to our next speaker, which is cultivating big data development in radiology.
Okay, so now that we've painted a picture of what the future may hold for radiology, we're going to try to give some idea of how we can get there. So we can take inspiration from the big data adoption cycle, which has been described and extracted from the business world. And that describes big data adoption as occurring at 4 stages: the education, exploration, engagement, and execution stages. Now basically, roughly, education stages is where you're learning about what big data means. Exploration is where you start thinking about what can big data do for you, and if you have specific problems in your institution that maybe would benefit from the insights that come from big data. Engagement is where you start to develop basic tools, so proof of concept implementation of big data methodologies. And then in the late stages of that phase, when you start to develop a sense of how things will look once you start to incorporate these methodologies. And finally, in the execution stage, that's when you've now accepted widespread adoption of big data, and continued development of these methodologies becomes a normal part of your standard operating practice. Now, translating that into radiology. So how can you recognize these stages in radiology? So in the education stage, that's when you have the invited lecturer come by and say, this is what we're doing at our institution, and then everyone's kind of listening in the audience saying, oh, that's a really good idea. In the exploration stage, which is where a lot of departments are currently, that's when you start to ask questions about, what data do we have in the DICOM headers? What data is recorded in RIS? Can we improve staffing? Because, I've noticed on Friday mornings, the chest reading room is always overworked. In the engagement stage, that's when you start to look at these pilot projects, right? So when you start to track turnaround times, you start to look at utilization of specific scanners. And by turnaround times, I mean radiologists report turnaround times. And then when you implement staffing changes in response to these data, where you can realize some cost savings. And then finally, in the execution stage, that's when you start to have access to the tools that we've been describing in our vision of the future of radiology. So, and like I said, most radiology departments are in the first 2.5 stages of this cycle. So what can departments do to make this happen? So we can invest in the future and the technology of the future by investing in storage centers. And again, we're talking about storage centers that are maybe not just behind a silo, that are standards-based and can be accessible by multiple stakeholders. and image-enabled PACS. When you talk about integration, implement infrastructure that allows cross-enterprise data integration, and developing the security and governance practices for this data. And finally, building tools that allow you to extract data, whether it's searching the RIS for reports or doing natural language processing, or the images themselves, whether it's computer automated detection, automated processing of images, or looking at the metadata. And finally, now that we've enabled the technology for the future, enabling people for the future. So, there are new fellowships in clinical informatics that will be important for providing individuals to fill these roles. Departments can facilitate collaboration between departments. And finally, departments can support individual investigators who are looking to either get developmental grant or departmental grants, or research grants either from NIH, NSF, or SIM, or actually even corporate partnerships in some instances. So, in conclusion, big data will feature prominently in medicine, and radiology is positioned to be at the helm. And the future of radiology and our role as radiologists will rely on big data techniques. And to realize this vision of the future, academic departments can take guidance from the big data adoption cycle and invest in technology and people for the next stage of radiology. Thank you very much.
Okay, thank you very much. In the interest of staying on time, we'll move on to the next talk, and if we'll answer some questions as we go along if we have time. Otherwise, we'll reserve questions for the end of the presentations. Next, we'll have the Clinically Oriented Academic Radiology Department Research Initiative presented by Drs. Ward and Decker.
I have to always do that because I'm so short. I'm sorry. Good morning. My name is Dr. Summer Decker, and I'm presenting here with my colleague, Dr. Rob Ward. Neither of us have any disclosures to prevent today. So when we started this task force last year, we came to the RRA business meeting with a problem that we were both looking to address. And we were hoping that we could find information that would help programs like ourselves. And we came to the RRA because the primary mission is to encourage and stimulate research in all radiology departments. And some of us, as we all know very well, these radiology departments look very different. Some of us are in very large academic institutions with hundreds of researchers, and others of us are in more clinically oriented programs. So we wanted to look at, is there untapped research productivity potential in some of these smaller programs that maybe we're not looking at or maybe we don't have access to, and what we could do to help address that. So as part of our task force, we sent out a survey last fall to programs that were receiving less than $1 million in grant funding. We were hoping to see what the state of the field was for these programs. And the problem we were looking at is, of these numbers of radiology residency programs, we saw that the median department size was about 38 staff. So we were trying to find the programs that were smaller than that, these small to medium-sized programs, if you will. And as we all are very familiar, there's a nationwide increased pressure for research productivity on our programs. I know at my institution, this is coming from the deans, our chairman, and we have things that we have to address like the LCME accreditation, ACGME accreditation. All of these different factors request and require more research productivity from faculty and residents. Unfortunately, this comes at the same time as decreases in grant funding nationwide as well. You see this with the decreases in federal funding for the NIH, but also in societal levels. With these decreases in funding, what you're seeing is larger programs are working together and setting up multi-institutional grant projects, and people have talked about it today in things like ACRIN, the lung cancer screening, ADNI. So you're seeing these larger multi-institutional collaborations, but sometimes some of the smaller programs don't qualify or we can't break into that. So it sets up a question, who is actually doing the research out there? And one of the things we looked at was publications over the last few years. And we looked at that and correlated with NIH funding. And what you see here on this table is the highest numbers of publications coming out and how that corresponds with federal funding. So as you see, the programs that get the most funding are the ones that are able to get a lot of publications. And as I mentioned, a lot of programs are starting to work together. And these blue arrows here that you can see, these are actually schools in California. And you see, even though they have different amounts of grant funding, you're seeing that they're working together. When we looked at the publications, they were often working as teams. And so the research output was boosted by all of them working together. So this is almost a mini network, if you will, within their own state. So this is the current trend that's out there. So as part of our survey that we sent out to all these different programs, we had over 300 and something people respond. And one of the questions we asked is, how many first authored scientific publications have you had in the last 3 years? Now again, we're focusing on those smaller to medium programs. And overwhelmingly, people said 0. So this is something that we were interested in, try to understand, why is this happening? First thing you have to ask is, are people even interested in doing research? Because maybe it's not a part of their program and they don't really care. And when we asked this on the survey, you had nearly 90% of the people said, yes, we are interested in doing research. And in fact, they went on to say that research, 90% of the people said that research serves as an important function to the prosperity of the field of radiology. And that about 65% said that it was important for their own personal career development. But as you can see at the bottom here, research as a requirement of your institution was only about 17%. So this trend, that you're seeing coming from the administration and from other programs of requiring research has not yet necessarily hit the actual departments. So this is something to figure out. Where's the problem? What's stopping us from doing research in our types of programs? And one of the barriers that was mentioned a number of times was lack of training. What we found was a lot of times faculty come from programs that don't have a lot of research, and then they go through that residency, and then they go on to their program, so they've not been trained in research skills. And so now they're required as part of their job to train residents in research when they've not had the training themselves. And in fact, I know the ACGME requirement, one of those is actually to train the trainers. That's part of their new requirements that you're seeing. So we have to figure out how to get faculty trained. And we also looked at a lot of programs, and a lot of them did not have any resident research curriculum. Things on how to write a paper, things about how to do basic statistics. A lot of the programs didn't have anything on the books for this. One of the other barriers that really comes up is lack of resources. And I know we've all talked about this over the last couple of days, but funding obviously is hard to come by. And when you want to start a project, you need pilot funding. And a lot of programs don't have access to that, much less to fund a full project, to get, to even go to the conference to present the project. Another thing was, and I've heard people say, well, just have your grant writers help you in your department. Well, I can only speak for my university, but I don't have a grant writer in my college, much less my department. So that's part of my job to work on that, but also for our clinicians. And I don't know about you guys, but I don't know how much time you have to sit down and write NIH grants that take sometimes a year and have a funding rate of single digits right now. So that's a big hurdle for a lot of programs. Biostats. A lot of our residents come to us saying, how do we do this? What can we do to do our own projects? But a lot of programs don't have access to biostats help. Manuscript preparation. I spend a lot of my time in my program helping residents. I was doing it actually this morning, working in those manuscripts, even how to present at a conference. And the other thing is we recognize that we are not at some of these very large institutions where they have a lot of researchers. So you have to find a topic that we can, that is relevant to the field, but also realistic. Things that we're not going to be doing certain bench lab projects because we don't have bench labs for our department. But what can we do at programs like ours? And so asking our participants, what barrier do you see here? Lack of experience was a big one, and lack of scientific writing and training. The overwhelming biggest barrier was time. And I think we can all agree that we all get pulled a million different directions. I feel like every day I get a new email of a new duty that I've been assigned. And you have clinical duties and teaching duties and administrative duties and committee duties, and they seem to make new ones every day. So looking at our survey, the biggest barriers were lack of protected time and overwhelming clinical demands. So we find ourselves, and I'm sure it's not just to the smaller, medium programs, but we're in this kind of almost vicious loop where we have a lack of resources, and that leads to a lack of production, which then leads to a lack of opportunity. As you know, to get the big grants, to get the big projects, you have to be producing. So it's almost this vicious cycle that these programs get in where you can't just kind of get out of this. So as part of our task force, we looked at what can we do to help these programs? And one of the potential solutions that we've come up as a group with, that Dr. Ward's going to talk about, is COARDRI.
Thanks, Summer. So the current research model is typified by the lone wolf. Synthesize a random hypothesis, keep it secret, recruit the fewest number of additional investigators, design, study, perform data collection, write the manuscript, and publish. Requires a comprehensive understanding of the literature. It may involve co-investigators, the lone wolf model, with similar expertise, and of course, knowledge of study design, data collection, methodology, statistics, and manuscript production. On the infrastructure side, funding, admin support, lab access, and most of all, time. Alternatively, the network model is best characterized through ACRIN, an incredibly successful network established in '98 with 76,000 participants and $100 million distributed to participating facilities 10 years after its inception in '98. ACRIN's designed as an individual institutions participating in parallel, thereby increasing power of the study. Each site is virtually independent but coordinated centrally. Each site must be equipped for data acquisition. Think of ACRIN as sort of a research model in parallel. Clinically oriented programs, by contrast, may lack many of the key components. The lone wolf model may not be suitable for radiologists at these programs or departments, and many of them will not qualify for ACRIN participation just based on logistics and infrastructure alone. But the question is there value in research for these smaller, mid-sized departments, clinically oriented departments? Do we need more research for the sake of research? Are journals being littered with inconsequential papers? Can smaller programs capture grant money potentially? So COARDRI focuses on the small to mid-sized clinically oriented academic departments. The way it's envisioned is that each department would bring a different component to the research assembly line. Think about it as research in series. So the general COARDRI structure, the task force sits above different subtask forces divided by areas of research interest, and they administrate over the recruits who are then supported by people within helping with design, manuscripts, and statistics, as well as mentorship. So the typical process is the subtask force generates the topic. We provide the topic for research for the recruits. A radiologist is recruited and then assigned a mentor, undergoes some training, some sort of cursory education with regard to that particular area of research, and then creates a study design through design support, collects data, and then authors a manuscript with both manuscript support as well as statistical support. So the published paper looks something like this, where the recruit is actually the first author. The last author is reserved for the subtask force member that came up with the topic generation or the idea. So when you build an instrument, what are you going to do with it? So here are some potential COARDRI topics. We felt that topics like these wouldn't really be well served by the departments that we're trying to target here. So what do you choose? What do you choose to do research on? So we're understanding the constraints of our infrastructure, but at the same time, we want to do something that's important, something that has value. So we came up with these 5 areas: imaging utilization, cost effectiveness, education, imaging health policy, and quality. Our agenda is to build evidence that demonstrates the value of the radiologist and radiology. So with these groups of radiologists within the mid-size and small programs, are they willing to collaborate? And we found that 70% were interested in a research topic generation. We give them the research topic, training in that particular area of research, training with respect to study design, statistical support, and manuscript production. The areas that were most popular were education and comparative effectiveness of our 300 respondents. Where are we today? What have we done? So at RSNA this year, the task force met with academic leadership. We discussed the preliminary survey results, mapped out a structure and timeline for the initiative, assigned topic generation to sub-task force members, and discussed project feasibility and potential barriers to success, as well as recruiting an advisory panel. So what's next? So this is our current state of COARDRI recruiting. There are members from all these institutions that are on board. Currently have about 40 people involved. We're currently in the topic generation phase. We'll be meeting at 10:30 to discuss that. We're building educational tools to be given the recruits after they get their topics. We currently have 13 radiologists that are eager to get started, and recruit assignment is thereby pending. So in conclusion, COARDRI aims to build a case for the value of imaging and imagers, features underrepresented segments of the academic community, creates a sizable virtual radiology department for potential future large-scale data mining and participation. Ultimately, through collaboration, we can globally pool our resources to overcome our local deficiencies. Thank you very much.
And actually, we have time for a few questions. Actually, sorry, there's a question.
Yeah, that's an excellent question. No, and purposely not. It's our feeling that what will happen then will just sort of be drowned out by the larger departments, agendas, et cetera. So we're sort of taking, I mean, we certainly, everybody's welcome to actually serve in the mentorship role, but in terms of first authorships, we're looking for recruits from mid-sized to small programs.
Have you thought about the possibility of doing like the big SIP, small SIP program? Like, you have larger departments mentoring smaller departments, or be part of the network so that they can actually leverage the resource like the biostats and so on, right? And designs and so on to help.
Well, we think that instead of going that route, that if we used focused mentorship, a few key people here and there, we can provide that ourselves and sort of be free of the domination of the larger departments. So I want you to imagine a radiology department that virtually, we're talking about maybe 20 or 30 departments 10 years from now, that is larger than any actual real department, and probably reflects the community far better than large tertiary care world referral centers.
Great. I just want to think with it as a chance of not creating competition, but synergy between different size departments, and also, leverage the resources that are already there. So.
Okay, thank you very much. Our next presentation will be on outcomes research in radiology, and our presenters are coming up right now.
Hey, good morning. My name is Matt Zigmont. I'm here with Jason Etri to review this year's task force on patient-centered outcomes research in radiology. Neither I or Dr. Etri have any disclosures. So in the next 15 minutes, I'd like to characterize patient-centered outcomes research, how it's being advanced in the national agenda, and the importance to radiology. We'll talk about sources of national funding and describe the internal prioritization process through the institute that's been created for this purpose. And we'll go over a recently funded example of a project from 2015 and talk about the methodologies that were involved in doing that project. In 2010, the Affordable Care Act established funding and the mandate for a nonprofit, non-governmental organization called the Patient-Centered Outcomes Research Institute. The Institute lists their mission as the following. They help people make informed healthcare decisions and improve healthcare delivery and outcomes by producing and promoting high-integrity, evidence-based information that comes from research guided by patients, caregivers, and the broader healthcare community. So the Institute's primary focus is to fund comparative effectiveness research based on questions and outcomes that matter to patients. And they're not the first organization to fund this type of research, and they're not the first funder to focus attention on the views of patients and other stakeholders, but it appears that they are the largest single funder currently to maintain comparative effectiveness research as its main focus and incorporates patients and stakeholders throughout the entire research process. So on their website, they call this research done differently. And at the bottom of this slide, you can see examples of patient-centered questions that focus on outcomes important to patients, including quality of life and morbidity, metrics that are not always the focus in radiology research. For example, given my personal characteristics, conditions, and preferences, what should I expect to happen to me? And what are my options? What are the potential benefits and harms of those options? So the Institute openly claims this fiduciary responsibility to the public to use the trust funds for research that will effectively fulfill their mission statement. In order to identify high value or high potential projects, the Institute created a methodologies committee to formalize both the prioritization process and methodology standards. And through public forum, they identified 5 topic areas to be national priorities. These topic areas were intentionally left broad and were informed by multiple sources, including the 100 comparative effectiveness research priorities that were developed by the Institutes of Medicine in 2009. The ACR also sent a letter of recommendations for priority topics in 2012 with recommendations for neurologic imaging priorities, quality and safety topics at the healthcare system level, and suggestions for linking national mammography databases to tumor registries. So the 3 of these 5 areas are particularly well suited to radiology. If you'll notice, the first area is focused on the assessment of prevention and diagnosis and treatment options, and serves to fund comparative effectiveness research to see what works best for people with particular health conditions. Number 2 focuses on healthcare systems, including using innovative health information technology. And then number 5 is focused on accelerating outcomes research and the methodologies behind them, and it includes building data infrastructure, something that radiology is well suited to get into. So the funding opportunities, the Patient-Centered Outcomes Research Institute is expected to receive an estimated $3.5 billion in funding from the trust fund through September of 2019. They've been gradually scaling up funding every year. For fiscal years 2014 through 2019, they'll have $650 million in funding annually. 20% of the funding is directed towards disseminated and research capacity building efforts. The Institute employs two funding streams. The first stream involves the investigator-initiated research where proposals are submitted in response to broad funding announcements, those 5 topics that we talked about. This stream involves patients and other stakeholders at every step of the process, and though it's typically submitted by the researcher. The second stream is the patient and other stakeholder-initiated approach, and it employs crowdsourcing and collection of research questions solicited from patients through either website or workshops. This eventually allows for construction of targeted funding announcements. So for example, in the first cycle of the Institute, 5 topics were chosen as targeted funding announcements, and they included treatment options for uterine fibroids, treatment options for back pain, addressing severe asthma in African Americans and Latinos, and preventing injuries from falls in the elderly, and then obesity treatment options. So both the individual and targeted funding announcements are submissions are judged based on prioritization criteria that Jason will talk about in a little bit. Our group searched the funding announcements on the COARDRI website, and we identified 13 projects to date that had imaging-centric focus. So that's only 13 out of the 365 projects that have been funded to date. So this highlights the relative lack of radiology participation in outcomes research, at least through this funding source. I'll hand it over to Jason. He'll walk you through our example in the prioritization process.
Thanks, Matt. So Matt's provided a nice overview of PCORI type research and funding mechanisms, and you can see that there's a lot of money out there for PCORI type research, and if you have any interest, I think the first thing you should do is go to the PCORI website and you can look up some of these research studies and you get a nice one-page summary of how that study was designed and how it incorporated all the patient-centered aspects that you want to see in a research project. I'm going to get into the design of these research studies because really the goal here, PCORI's goal, our goal in having patient-centered outcomes research is to identify an important research question, a relevant research question, and then to design research that has the greatest impact on patient-centered outcomes in a cost-effective manner. So these are some categories that you can use in the prioritization process. This is adapted from what PCORI uses to look at their funded studies. The impact of a condition on the health of individuals and populations, the potential for the study to improve healthcare and outcomes, technical merit, patient-centeredness, patient and stakeholder engagement. And towards the end of the talk, I'm going to highlight one particular study that I think embodies every one of these categories. And you can see here that no lone wolves are allowed, right? Another part of the prioritization process in the study design is determining what level of outcomes data you need. So if you have technologies or interventions that affect a small number of patients and have a low cost, you need low levels of outcomes data. If you have technologies or interventions affecting a large number of patients with small expected clinical benefit, then you need a high level of outcomes data. And once you've gone through all that information and you've defined your research question, you've got your evidence, you have all the elements of your patient population, you've taken your patient's question and formed it into a research question, then you use a translation framework to develop a translation table. The whole point of the translation table is to help you pick the best study design. There's a lot of different study designs you can use to do patient-centered outcomes research. And what the translation table does is it compares and contrasts all the different study designs, and it tells you what all the trade-offs are looking at different parameters of your study. The trade-offs involve your internal and external validity, the precision, the timeliness of your results, the resources required to go into the study, and that's what helps you decide what kind of study design best fits answering your particular question. Another part of that translation framework before you've come up with your final study design is to use the methodology standards that have been published by PCORI. Now, this is not meant to be a comprehensive list of standards. This is really, the PCORI Methodology Committee went through studies that have been published and described, and they found areas where there were substantial deficiencies or inconsistencies in how methods were applied, or where there were barriers to effective dissemination of research results. And they came up with these 47, basically what you can call best practices that you should use when you design a PCORI type study. 6 of these categories are really cross-cutting standards that apply to every type of PCORI research study, and then another 5 categories are more specific to certain types of PCORI research. So let's say your study involved a cancer registry. There's methodology standards that you should use for your data integrity. So I said you had a lot of different study designs to choose from, but one that's been talked about as being ideal for radiology-centric PCORI type research studies are pragmatic trials. So what pragmatic trials do are they compare patient-centered outcomes between at least 2 different interventions in real-world settings. So you can compare and contrast this to your traditional randomized controlled trial. So on one end, you have your traditional RCT where you've got very high internal validity. You've got strict internal and inclusion and exclusion criteria. You've got a very controlled environment where you administer the 2 different interventions. Pragmatic trial is on the other end of the spectrum, where you don't have those inclusion and exclusion criteria. You take all comers with the disease, and you say, we're not going to care so much about what the environment of the intervention or the expertise of the people administering the intervention. We want to see how these interventions are going to work in real-world situations. The benefit of using pragmatic trials is that when you find that your interventions differ, you're more likely to find that when you give that intervention out to the general populace, you're going to have the same effects, right? So the benefits of a pragmatic trial is that you have higher external validity and generalizability. The problem is you have much lower internal validity. That's what you get with your tightly controlled, randomized controlled trial. There's a couple other downsides to pragmatic trials. You're less likely to produce statistically significant results, and that's because you're not controlling the environment as much as you would with the traditional RCT. And there's barriers to the acceptance of these alternative trial designs. When I was a med student and a resident, the gold standard for proving one intervention was better than another was a traditional randomized controlled trial. And it's going to take time to convince the scientific community that pragmatic trials can be as effective and probably better suited for patient-centered outcomes research. So I want to talk about one very well-designed trial that was recently funded by PCORI in 2015. It's called a preference tolerance randomized controlled trial of personalized versus annual screening for breast cancer. So if you think back about all those categories I listed in the prioritization process, this project has every one of those. It's got 3 objectives. One is to compare 2 strategies to determine whether personalized screening for breast cancer is as safe as annual screening, and if it reduces false positive results and overdiagnosis. This is a very important problem for medicine and for patients right now. Another objective is to determine whether women readily accept personalized screening and if knowledge of their own risks and the reasons for less frequent screening will reduce or at least not increase their anxiety about breast cancer. That's the patient-centered outcome. The third objective is to determine whether a personalized approach will lead to more of the highest risk women deciding to use strategies that can prevent breast cancer. So by definition, a patient-centered outcomes research project has to have patient-centered outcomes. They use 3 validated assessment tools to measure anxiety in women and worry in women with breast cancer. So that's the patient-centered outcome. Stakeholder engagement was another big part of patient-centered outcomes research, and you see that for this particular project, they've got everyone involved. It's got the clinicians, the researchers, the payers, the patients, and the patient advocacy groups. So remember, all these different groups played a role in defining and refining that research question and choosing the study design. Just a diagrammatic representation of what this pragmatic randomized controlled trial looks like. So when the researchers conceived this project, they felt that when a woman is faced with breast cancer screening and breast cancer treatment, that they always have a choice. They have a choice in how they get screened, they have a choice in what therapy they have, and they wanted to preserve that choice as a fundamental part of this research project. So when you have eligible patients, the first thing they do is they counsel those patients on all the risks and benefits of different screening, the risks and benefits of being part of a research trial, and then they allow the patient to choose, do they want to pick their screening arm? Do they want to be in the annual screening or the personalized screening, or are they willing to go into the randomization cohort? So the project starts with a choice, and so that's one of the differences between your traditional randomized controlled trial and a pragmatic trial. And then the randomization process puts women in either the annual or the personalized screening. These are just some of the factors that are used in determining a woman's breast cancer risk. The factors are listed at the top, and then based on an updated breast cancer surveillance consortium model, they're stratified into different screening approaches, and those are listed at the bottom. So that's a brief summary of what one of these projects look like. If you go on the PCORI website, it gives summaries of all those different projects and different contact people. I'm going to pass it back to Matt now, just talk about a few other opportunities available in imaging for PCORI research.
We only have a few minutes. I think it's just important to highlight that PCORI represents a significant funding source that's currently underutilized by radiology. And as our practices continue to focus on transitioning from pay-per-click to pay-per-performance, the evidence from outcomes data will help define imaging value, define measures for cost reduction, and improve quality. And we're well positioned to promote outcomes research and topics related to disease screening, treatment-related trials, and the example by Dr. Esserman highlight this, the one that Jason was talking about, and it shows the potential application to other screening paradigms, including lung and colon cancer. In fact, on that list that we had, one of the other 2015 funded studies was a lung cancer screening trial. So more to come. Imaging is often the foundation for these screening studies, but it requires collaboration on many fronts, including the different specialties, payers, and patient advocacy groups. So another area that we'll highlight in our review, radiology is currently involved in developing decision support, maintaining appropriateness guidelines for imaging, and as the decision support becomes implemented across the country, it will create a great interface for our specialty with other specialties and allow dissemination of those evidence-based guidelines. There's a tiny URL here if you want a copy of the slides. Any feedback or questions would be appreciated. I think we've got a minute.
Are there any questions?
Great. Thank you.
Okay. We can move on to our next talk then, which is simulation in radiology. Okay, so this is our next task force is on simulation in radiology. This is the number of our task force members here, as well as our presenting members. None of the presenters have anything to disclose. And I'm Bill Offerman. I'll be doing a little introduction on simulation. And so medical education has traditionally revolved around the apprenticeship model outlined by Flexner and Halstead, which is very effective, no question about that, but the model nonetheless does have a few limitations. One is that it's time consuming. It really involves virtually one-on-one interaction between the trainer and the trainee, so to speak. The educational experience may be limited by what's seen on clinical service. If disease A is rarely seen at a certain hospital, the residents at that hospital probably won't be very familiar with the imaging findings of disease A, as well as patient safety, as less so maybe in radiology than more fields which are more interactive with patients, but non-recognition of acute radiologic finding could have adverse patient outcomes. Consequently, in many fields, simulation has been used to bridge the needs of education that may not be met in the traditional apprenticeship model and go past some of these previously mentioned limitations. And while it does not replace actual training experience, it may be useful as a supplement. And simulation has been successfully used in many fields, aviation being a very notable example. And many advances in hardware and software have made simulation a more feasible tool to supplement existing educational methods in radiology. And now the rest of our team will outline what some of those tools might be.
Good morning. My name is Michelle Mendrada-Lala. I'm going to just talk briefly about simulation training for procedural skills in radiology. So as a brief introduction, procedures are used in nearly all subspecialties of radiology. Expertise is obviously a very important goal, and successful training of procedures requires repetition and feedback on performance for the trainees. There are many phantoms that do currently exist for simulation training of procedures, and many medical simulations that are already in place have actually shown that skills acquired via simulation can actually be transferred to a clinical situation. Now I'm just going to briefly give a couple examples of different simulation models that currently exist in the different specialties of radiology. So we'll start with pediatrics. Pediatrics is actually unique because of the limited opportunity for the trainees to gain experience. Most residents are on pediatric rotations, very limited in their residency, and of course there's very few cases. One example in peds is that of intussusception reduction, which uses a baby doll model, a bulb insufflator, and pressure data, which is transmitted to an interactive computer program in order for training. Ultrasound-guided procedures is another area of radiology, which is used in many subspecialties. Use this in mammography, musculoskeletal radiology, cross-sectional interventional, vascular interventional. Now, ultrasound is unique because it requires targeted needle placement and good hand-eye coordination. There are many different phantoms that exist. Here's an example of a blue phantom, which has many targets. As you can see on the lower image, there's an anechoic lesion, which the needle is placed into. Studies out there which have evaluated simulation training for ultrasound procedures do exist, and these two graphs are from one study which actually showed improved performance, which was statistically significant when residents performed a procedure from start to end, pre and post procedure on the top graph. On the bottom graph, you actually see that there was improved acquisition of technical skills such as needle placement pre and post procedure. And another study, or a few other studies out there, have actually shown that these skills acquired during ultrasound training can actually be transferred to the clinical practice. CT-guided procedures, again, used in many specialties of radiology, musculoskeletal, cross-sectional, even neuro. So here's an example of a 3D foam phantom used with CT fluoroscopy, which has multiple targets in it, as you can see to the side at the top. These graphs here actually were from a study which actually showed that training with CT fluoroscopy pre and post procedure decreased fluoroscopy times, decreased radiation dose, decreased needle redirects, and decreased overall procedure time for residents pre and post procedure. Now, vascular radiology, obviously lots of procedures there. However, the opportunity for catheter-based interventions are decreasing because of increasing use of CT angiograms. As a result, there's decreased experience for tactile and visual feedback and a need for improved hand-eye coordination. An example of simulation for vascular radiology is that of iliac intervention. And a study which actually assessed trainees pre and post training showed that there was decreased procedure times, decreased contrast volumes used by the trainees, decreased fluoroscopy time, improved balloon catheter and stent choices by the trainees, and finally decreased use of different wires and stents. So a lot of studies have shown there's definitely utility in using simulation for procedural training. And finally in neuro, there are lumbar puncture modules as well as epidural injection simulators, which are linked to computer tracking for needle tip positioning. Okay, our next.
Hi, I'm Carolyn DeBenedictis, and I'm going to talk today about simulation training of non-procedural skills in radiology. We're going to start off with interpretive skills. There's a new emphasis in radiology residency training toward competency-based medical practice. Physicians must show adequate training and preparedness prior to being allowed to perform specific levels of care on actual patients. An example for this is a trend toward radiology residents being evaluated for their preparedness prior to taking overnight call alone. Taubin et al. Described a radiology simulator which mimics a PACS. Standardized training for residents prior to being called in the emergency room has been a useful application of this simulator. Ganguly et al. Gave first-year residents an intense lecture series and DICOM-based simulation training with pre-selected cases, and then compared them to senior residents who only had standard residency training. The first-year residents who received this simulated training performed as well as the senior residents on computer-based ER simulation. And down here in the corner is an example of a PE simulator for residents to learn how to identify pulmonary embolists that's out of the University of Iowa. Teaching files have now been converted into web-based teaching files at many institutions. This allows for ease of access and ease of sharing with other institutions and allows teachers to now teach more and compile and spend effort doing that less. The American College of Radiology has recently developed teaching content creation system that incorporates a cloud-based PACS system called the Radiology Content Management System, or RCMS. And this allows for multiple institutions to collaborate and share fully manipulable teaching cases and educational content worldwide. Ultrism is a sonographic simulator, and this allows for training and testing of radiology residents on their ability to scan and interpret different types of ultrasound cases prior to taking call or doing things independently. And it allows us to find their weaknesses and address them. So let's move on to team-based training and crisis management. With improvements in iodinated contrast, contrast reactions have now become a less common occurrence. Thus, exposure to contrast reactions is limited for radiologists in residency. However, it's important for residents to confidently recognize these reactions as well as manage contrast reactions despite this lack of exposure. A large number of contrast reaction simulation programs have been developed employing standardized patients or high-fidelity mannequins to mimic an actual contrast reaction. Computer-based or online sets of scenarios providing dynamic feedback in response to trainees' decisions are also being used. Respiratory arrest during sedation is another area that is not commonly experienced during radiology residency, but when it does occur, residents need to be prepared to handle it efficiently. So sedation analgesia simulation is an effective way of training radiologists to improve patient safety. So let's move on to professionalism and communication. Effective communication has become an important part of radiology. Most practicing radiologists did not receive formal training in communication skills and professionalism as radiology residents. Consultative and communication skills are now part of the ACGME 6 core competencies and milestones for diagnostic radiology residents, and residency programs are now having to find ways to teach residents these skills as well as assess them effectively. Allowing physicians to rehearse communication skills through role-playing allows for self-reflection and in turn improves physician communication skills. Training courses can allow radiologists to practice delivering bad news and shows improved performance through simulation, and it alters attitudes and beliefs about importance of psychosocial issues and communication. There are numerous programs that do this, such as Perks at Children's Hospital, and at my institution, we actually do a general OSCE for communication skills using standardized patients.
I'm Linda Probin, and I'm just going to briefly tell you about hybrid simulation and in situ simulation. So hybrid simulation is when more than one type of a simulator is used, and it's commonly done with the use of a mannequin and a standardized patient. So this increases the realism of this scenario, and you can have more complex and challenging simulation scenarios, and you can assess several domains. So in this picture here, my resident on the right of the screen he was asked to perform a procedure. We have a standardized patient and a technologist. So he had to consent the patient, prep and drape, perform a procedure. So her left leg is actually over the side of the bed, and we've placed the simulated leg that's got soft tissue lesions within the insert there so he can perform the procedure. And we videotape these, and then we debrief, and we are able to assess communication, collaboration with the technologist, his ability to obtain consent, medical knowledge, and technical skills. So multiple different competencies are assessed. In situ simulation is performed in the actual clinical environment. So it's really close to a real life experience, and it usually involves a healthcare team. And this enables the group also to look at local system challenges within the environment, and it's more complex. And again, you can assess several domains. So in this example, my resident who's at the head of the patient was on call, and we asked him to come to manage a contrast reaction in the CT scanner. And we had a technologist and a nurse helping him. And so you can see that when he arrived, it was a simulated mannequin. And so he had to perform the resuscitation of this patient or mannequin. And you can see here that it actually showed us, in fact, there's not much room at the head of the table in the CT scanner. He was almost sitting within the center of the scanner. So it told us a little bit about our environment and how we had to manage things. So it's really useful that way. Again, you can assess multiple domains, team-based training, and that sort of thing.
Hi, I'm Allison Chetland. So you've heard a number of simulation methods. I'm going to talk a little bit about how to assess the students. So obviously assessment of the trainee's performance during any simulation module is necessary to identify their strengths and weaknesses so they can improve patient care and become better doctors. One method that we've talked about a little bit is by videotaping the scenario. This doesn't work in every situation, but we found that a number of studies have proven that formal assessment by more senior staff physicians was really important to the trainees' growth because they need that debrief to really assess and grow. So there's many tools for assessment of simulation skills. There's different psychometric tools which can evaluate interpersonal and communication skills, and as we've heard, these are becoming more important. There's also checklists for procedure skills and pre and post test for knowledge. One of the psychometrics is a behaviorally anchored rating scale. This can be designed in any way for any learner in any situation. You design it yourself based on what you'd like to assess. And the result is a rating scale for each task. Behaviors are rated for each member of the healthcare delivery team. So if you have a situation where there's numerous learners, you could have a different behaviorally anchored rating scale for each learner. The advantages of using this is it's behaviorally based, it's very easy to use, it's equitable, individualized, and it's very action-oriented. Here's an example I just made myself. If you were establishing a professionalism curriculum, you would want to make sure that your learner established an appropriate environment. You would want to make sure that they engage the patient appropriately and help the patient to achieve an approach to the event. And you could design a scale, for example, from 1 to 10. 360-degree evaluations I know are used in numerous areas within our own radiology department. I'm a mammographer, so I have my mammography techs, my nurse navigators, the MOAs, and other physicians that we frequently interact fill out 360-degree evaluations of my own residents. And it's very, very helpful because I don't always have to be the bad guy. And the residents can hear from numerous different members of the healthcare team. 360-degree evaluation forms include a checklist of items pertaining to important interpersonal and communication skills. And each item is rated using a Likert response format. And like I was mentioning, you get feedback from numerous different members of the healthcare team. This is just an example of one that I typically use with my residents. The Kalamazoo Essential Elements Communication Checklist is just another type of psychometric, and this evaluates 7 key elements of physician communication, such as did the physician build a relationship, open the discussion, gather the information, understand the patient's perspective, share information, reach agreement, and provide closure. And this is an example of the Kalamazoo Essential Elements Communication Checklist. Checklists for procedural skills, these have been around for a long time. It's a very quick and easy way to assess whether your learner has done all of the essential components of a procedure simulation scenario. And pre and post tests for knowledge also have been around for quite some time, and these can be designed for the learner and for the situation. Next, we're going to hear about competency.
Morning, I'm Bradley Pua. I'm going to be discussing how we can leverage simulation in measuring our competencies. So really there has been an evolution and shift of medical education from a time base where we're looking at classroom time, we're looking at actually credits, to a competency-based education where we're all very familiar with this radar plot of the ACGME core competencies. We're looking at our individual trainees as well as looking at our specific training programs. When we look back into sort of traditionally how we assess competencies, many talk about the Miller's Pyramid, which if we go from the largest part, the base, to the apex, if we look at a specific skill, it goes from knows to knows how to shows how to does. Well, how do we actually assess these competencies? In regards to knows or knowledge base, many always talk about multiple choice questions. Knows how, we always talk about free text questions. Shows how and does, and really the top of this pyramid is where we really can leverage simulation, where we start using things like OSCEs and more high fidelity simulators. If we turn this pyramid on its side, we will recognize the milestones. So really, for each specific milestone, we can actually assess how our trainees are actually getting to specific areas towards graduation. So we've already talked about OSCEs. OSATs is really an OSCE, but for a procedural technique. But if we take a step back and look at specifically, if we're using any assessment tool, what are the key features assessment tools need to have? They need to, one, there has to be an observation of performance and assessment of an end result. If you're asked to place a central venous line, it's not about how long it took to get there, but really the quality of getting there. Adequate sampling of skills and content to be tested. There has to be an analytical approach to assessment, as Dr. Chetland mentioned, checklists and global rating scales. And it has to be objective. Utilizing these checklists will become more objective. And of course, there needs to be a feedback loop of the evaluation, the teacher, and the person being evaluated. These tools really can be separated into observational and non-observational tools. We've already talked about the global rating scales and checklists. Really, this is a quick example of what we can do in OSATs. This is a simulation, an observation of someone placing a percutaneous nephrostomy tube in a phantom. You can look at all sorts of different things, from time and motion, how they handle their assistance, whether or not they're using the appropriate scalpel. There are some limitations and biases of observational tools. Secondary to the rater themselves, how experienced they are in placing a percutaneous nephrostomy, or if they actually like the physician they're working with, et cetera. This question actually was recently validated in a meta-analysis of 45 studies looking at checklists and global rating scales, and they found that the biases were not really as large as one had thought. Moving on to non-observational tools, this is an example of a computer-based measurement of events. Homegrown system, a trainee watches how to place a port, then they're asked to place the specific steps in the proper order. They are logged as to how long that it took them, as well as the number of errors. But that's a very simple example. We can go further. We can go to motion analysis. We can go to weighting of events. If we look at the top right-hand corner there, you're asked to place green and orange pegs over. You can actually look for motion analysis or weigh specific events, such as whether or not you go through the carotid artery. And finally, where's the next step? We can go to really, once we validate it better in terms of how we translate the virtual environment to the actual operator and real life environment, we can start talking about whether or not we can use this for credentialing.
Hi, good morning. I'm David Sarkany, and I actually get to do the fun stuff, show you the toys. I'm going to talk about current simulation equipment and software. We usually divide this into 4 different areas. Part task trainers are models that are used for a specific regions for teaching and assessing specific skills. So for example, we have this arm as a part task trainer. It can be used for IV placements, PICC line placements, arterial punctures. We also have neck central line placement, lumbar puncture, as well as other specific regional simulators for different kinds of procedures for thoracentesis and paracentesis. A real fun part task trainer, which was discussed earlier, is ultrasound simulator, which not only allows for teaching biopsies, but actual technical skills of scanning of your resident, your medical student, even a physician, with respect to Obviously, it's very good for simulation of biopsies. We use phantoms. You can use commercial phantoms. You can make up your own phantoms. This is an example of a blue gel phantom with actually a raisin, which is simulating malignancy. But you can have different kinds of phantoms depending on how much your budget allows. This is the more classic, which we talked about also a little bit earlier, that when everybody talks about simulation, computer-enhanced mannequins. These are usually life-sized models that are hooked up to computer software. They can show you physiologic and pathophysiologic conditions and human conditions. And they're really great, as was discussed a little earlier, for contrast reactions, sedation complications, interventional procedural complications, and team crisis management. So more specific for radiology is the PAC simulators, where there's preset images that allow the learner to interpret as well as give a report. And this allows for real-life reading room analysis. So as shown beforehand, the University of Iowa, in conjunction with the ACR, has something like this, and a lot of institutions are developing different ways of doing this. And finally, virtual reality simulators. These are the newest simulators that are out there, and they're really commonly used in interventional procedures. What they allow to do is the user interacts with a computer display, which simulates the real world. You get auditory, visual, or possibly tactile feedback that can tell the user what they're doing wrong. And like I said, it's usually used for endovascular procedures.
Okay, and so I'm sorry, we're kind of running out of time here. So we'll have time for your speakers at the end of the session. Our next talk will be on the value of value of imaging in healthcare, and our speakers are here.
Good morning. Thank you for staying for the last task force, Value Imaging in Healthcare. I'm Ann Duong from Emory University, and my co-presenter is Gilras Sadig, also from Emory. We have no disclosures. These are our task force members, and I thank them for their contribution. Last month in the New England Journal, the Secretary of Health and Human Services announced that now that they have expanded healthcare, they're going to be changing their focus to incentivizing higher value care and increasingly tying payments to value through alternative payment models. And they have set it their target as to have 30% of Medicare payments tied to quality and value through alternative payment models by the end of next year, and 50% by end of 2018. So you probably hear value a lot more this year in our talks, and I've counted the number of times value has come up in our talks than in the previous years, and this mantra has continued to grow. So the goals of our task force are to define value and also to show ways in which value has been demonstrated in radiology. So what is value? How do we measure it, and how do we reward value? If you look up value in the dictionary, it's defined as the amount of money something is worth, but it's difficult to put a price tag on different components of healthcare, and the value depends on which perspective you're looking from. And since we have the patient at the center of the healthcare, patients want high quality care. They are increasingly paying for their own care, so they want to be able to assist in the decision making. And Porter and Lee, in their landmark article in the Harvard Business Review, states that value should be defined as the outcomes that matter to patients relative to the cost of achieving those outcomes. There are other stakeholders we should keep in mind as we're looking at value in radiology. The providers are looking for high quality evidence as to which diagnostic tests to provide. They're also looking at declining reimbursements. The healthcare system is competing for patients and trying to coordinate care through these large organizations and accountable care organizations. Insurance payers want to know what the best test is for their money, and society as a whole wants the healthcare system to be sustainable. So one way to look at value is to think of it as quality divided by costs, or bang for the buck. You may have seen this equation before. This is a way to frame the quality in value. Gary Kaplan's equation, we know that outcomes is tied to quality, but also service. We're increasingly asking our patients to fill out satisfaction surveys, and waste is inversely proportional to quality. And also, we should also think about the appropriateness, because we may provide great service, good outcomes, but if the exam shouldn't have been done in the first place, then we haven't provided quality. I'm going to skip over the comparative effectiveness research. We had the Pragmatic group talking about that, but we need this type of research in order to inform our patients and other stakeholders in helping them make decisions. There are definitely some challenges in radiology with regards to comparative effectiveness research. The technology is rapidly updated. Our ordering is not done by ourselves, but by other physicians. There's a lot of variability in interpretation, and tracking and assessing of findings is difficult to do. But these also present as opportunities for leadership and research in our field. And again, PCORI is a way to get funding for this type of work. So here's an example of comparative effectiveness research, lung cancer screening, another hot topic. We know that low-dose CT is better than chest X-ray, but at what cost? And there's different cost models out there. In general, it's, the cost is such that it's less than what we would, meets lower than the threshold in which we would provide the payment. So another example of comparative effectiveness research is CT versus ultrasound for nephrolithiasis. There's no difference in outcomes, so it makes sense to use ultrasound because it's the less expensive test. You've all probably heard of the Imaging 3.0 campaign, which is encouraging radiologists to lead in defining value and also demonstrating value. So we have examples that show value beyond image interpretation. We know that outcomes is important, but there are other things that we do that also provide value. And that includes exam appropriateness, decision support, standardization of practice, as well as communication to our patients and our referring physicians. So many of you may have seen this slide before, the image value chain. This is where radiologists touch patients' lives in their care. This was shown by Giles Boland in his articles in the JACR. As we previously discussed, if you have an exam that is not appropriate, then the quality is zero. So if the appropriateness is zero, the quality is zero. There are a number of organizations that have appropriateness criteria and guidelines to guide appropriate imaging. One of the best known to us is the ACR appropriateness criteria, which stratifies tests for specific indications into whether it's appropriate, uncertain, or not appropriate. Recently, the CMS demonstration project has concluded and presented its findings. This demonstration project used appropriateness criteria in decision support in computer order entry. But unfortunately, they showed that there was no effect on appropriate ordering. There was no change in utilization, and physicians were very frustrated with the system. They found that over 60% of the orders didn't have guidelines, and the feedback was given to them after they already put in the order. So I think the value here was not demonstrated partly because of the methodology of the project. There are other institution decision support systems that have shown decrease in the rate of growth as a result of implementation, but part of this could be a gatekeeper effect, is another hurdle to go through. There's also more targeted decision support that is based on clinical decision rules that have shown some success. One example of that is the pediatric head trauma. decision rule, which has shown increase in the number of appropriate imaging. And this, unlike the ACR guidelines, is a decision tree. So it tells you not just what to order, but when to order it and when you should just observe or use another test. Last year, as part of the DocFix 2 bill, or the Protection of Access to Medicare bill, passed in April of last year, the government decided to mandate decision support by January 2017. So whether or not we have the robust evidence that we need, we're going to be doing this. And I think there's more work that's needed to provide robust guidelines to make the decision support systems more user-friendly. And we also need to work at a local level with our ordering providers to get buy-in and be meaningful. So now I'm going to turn the podium over to Gelera.
Good morning, everyone. Hopefully within the next 5 to 6 minutes, I'm going to talk about some of the examples of value of imaging on behalf of our task force. One of the examples is standardization of practice, and as you know, I mean, it's an effort to kind of reduce the rate of unnecessary variation. By unnecessary variation, I mean same patients with similar symptoms come to a physician and they are getting different tests, which results in either overutilization or underutilization, and has impact on patient care and healthcare costs. So standardization of practice is a way to reduce this. One of the examples of that was creation of DICOM, which provides an opportunity to share the images with the physicians from the same institution or other institution rather than re-imaging patients and like adding cost to the healthcare. Another example is the ACR dose index registry. Before that, different institutions for similar exams, let's say CT chest, and same patient characteristic, they were giving different dose. After the ACR dose index registry, although the dose is not still similar, but they have a benchmark to optimize their dose and basically ensure safety and quality imaging for the patients. Another example is use of standard language in our report. Fleischner Society guidelines is an example that if two different chest radiologists see a same nodule, give same recommendations to our ordering physician. Other examples are a series of white papers that are published in ACR, and it gives basically guidelines about the incidental findings that we find on CT and MR, and basically having similar recommendations for those for those incidental findings. Speaking of standard language, BIRADS is a good example and successful example of having similar impression and recommendations for patients with basically similar findings. And in an effort, I mean, to follow BIRADS, there has been other, groups to provide LIRADS, which is for liver imaging, prostate imaging, PIRADS, head injury imaging, HIRADS, and then LUNGRADS, which is for lung imaging. So another example of value of imaging is patient-radiologist communication. There was a survey in 2004 asking radiologists, and they responded that only in 60 to 66% of cross-sectional imaging they are present. In 60 to 66% they are not present during the performance of examination. And we all know the percentage is probably more than this. In 79 to 90% of cases, radiologists said that they do not even meet the patient. So many patients believe that the clinician ordering the examination and receives the report is the same person who interprets the exams, and basically we are invisible to our radiologists. So there are some barriers for this patient communication, and these include, first, radiology offices are often distant from patient rooms. There is lack of consulting rooms, and then some of them also depends on the radiologists themselves, because we always think, okay, we are busy, we need to take care of this list that we are reading, so we don't have time to talk to our patient. And even if we have time, we think this is not going to add much, to our imaging report. But patients have preferences with regard to this too. Survey results shows that patients prefer to receive imaging examination results from the radiologist at the time of examination rather than later from their referring physician. And they prefer to have prompt access to radiology results regardless of the specific findings. But on the other hand, clinicians have concerns. They think disclosing results directly to patients may result in increased patient anxiety, and it has associated negative impacts on the primary clinician's workflow, and they're going to lose their control over their relationship with their patients. But the fact is that, in this era of changing healthcare, public recognition is important. And there has been some efforts in improving that, like Face of Radiology campaign or Imaging 3.0. And basically what they're all recommending is having contact with patients during the exams, which in some divisions, such as breast and IR, we have been successful. Direct communication of imaging results. Having online education materials that are readable. Studies shows 80% of Americans find their healthcare information online. And then American Medical Association says an average American reads at 6th grade. Studies have evaluated the readability of online education materials on radiology websites, and they all show they are written at 9th, 10th grade, significantly high what an average American can read. So basically having online education materials more readable is another effort. And then construction of radiology facilities that promote comfortable interactions between patients and radiologists. So finally, the last example is referring physician radiologist communication, how to become a champion to your referring physician. So we know for the majority of our patients, our report is the only way of our communication with our physicians. And if we don't write this report well, it may result in mismanagement of patient care and malpractice suit. So referring physicians, many of them were surveyed, and they prefer structured and itemized radiology reports as opposed to free text reports. They prefer that we give them recommendations in the report on further imaging needed. Oncologists specifically, they prefer that we have a dedicated structured measurements section for the tumor progression or improvement, and also providing them a graph or table of these measurements. Multimedia embedded radiology report is another example, meaning that we add the image with the positive finding in our report, or at least have a hyperlink in our report, so that if the referring physician clicks on that hyperlink, it refers them to the image that we are talking about. And basically, surveys shows that referring physician thinks this saves time in understanding the findings. It increases their confidence in treatment plans, and it has also some marketing aspects. Many physicians preferentially refer their patients to facilities that offer these types of reports. Radiology consult is another way of our communication with the referring physician. It can be through like usual ways, such as just talking to them on the phone, paging them, writing them an email, or they come to the reading room and we go over image. But there are some other ways, such as, there has been a study that radiology residents were rounding with the medicine teams and going over the images during the rounds. There has been a study in Johns Hopkins that they developed basically an application which integrates with PACS, and they were teleconferencing with the referring physician, and then finally participating in the tumor boards. And then last is the reinterpretation of outside images, which lower cost of reimaging, it lowers radiation exposure of reimaging, and it alters clinical management. I'm going to pass the mic to Dr. Duong for the last slide.
So clearly in defining and demonstrating value, there's opportunities for research. We're now going from just deciding whether a test is good to is it a good deal, and that's comparative effectiveness research. There's also other areas, value beyond our image interpretation, that we can show and define value. So thank you, and we'll stay for questions at the end.
Yes, so are there any questions for this last, our last speakers here? Okay, if not, I would like every speaker who's spoken today to come up front, and we'll have just questions for any of the sessions we had today right now. So everyone come up who spoke. Come on up, everyone. And any questions at all, please ask them now, and then we can, of course, have other discussions a little bit later.
So I have one question for all of you. Do you think some of the task forces can work together? Like, you know, maybe the medium-sized and small-sized research departments can work with the people in value-based care to come up with projects to, right, actually work along those lines and so on. Because there's so much opportunities between the task forces to actually cross-fertilize. So something can be done, I think. From a white paper to true implementation, there's still a long way to go. So working together between the task forces may facilitate that. So we can talk more about that in our business meeting on Thursday.